Today, I want to talk to you about the how-to of successful treatment. So last presentation, we talked primarily about assessment and intervention, and we kind of talked briefly about ERP and how it works. I really today want to give you the insight to know a little bit more what to do in session. So my biggest, I guess, pet peeve when I would go to presentations is I would get really excited to see a presentation, learn something new, try something new. And I felt like a lot of the presentation ended up being, 3/4 of kind of theoretical and background and diagnostic criteria. And then I would be like, okay, just tell me what to do. Just tell me what to do in the room. And we'd kind of get to the last 10 minutes and I'd be like, okay, now here's the good stuff. And then the presentation would be over. So it felt a lot like, saving the good stuff till the end and then not getting to it. So my goal here really is to give you an understanding of actually what happens in the room when you're treating OCD. So I'm going to try and make it really practical. I'm really not going to spend a lot of time on research or articles or diagnostic criteria or anything like that. I'm going to assume that you guys know most of that. So I really want to give you some groundwork, right? So an hour and a half is not enough to become an OCD expert. If you are planning on seeing a lot of clients in your practice with OCD, I definitely recommend more in-depth trainings. The best one that I recommend is the International OCD Foundation, or the IOCDF's BTTI training, the Behavior Therapy Training Institute. So that you can go on the IOCDF website and sign up for email alerts. It's a 3-day training. They happen all over the country. They're very in-depth. They're also very hard to get into. So please do sign up for the email if you're interested, so you can kind of pop on right away when they release the dates and the trainings, because it does go very fast. I also have a couple of resources at the end for you guys if you're interested. The other thing I wanted to mention is just, if you are interested in becoming an OCD therapist, please get trained and start seeing clients with OCD, because it's a really, really wonderful area. And it's really underserved in that we just don't have enough therapists to treat OCD, and we don't have enough therapists to treat OCD well. It's a really gratifying field. People tend to do really well. The treatment is very successful. So I encourage anyone that's interested in really kind of carving out a niche for themselves with OCD to go ahead and do so. And feel free to reach out to me after the presentation if you have any questions about how to do that. Let's see. There we go. Okay. So today's agenda, again, my goal here is to really teach you guys, what do I do in the session? What happens in the room? So I am going to go over the assessment and diagnosis of OCD pretty briefly. I want to talk about exposure response prevention and creating a hierarchy, and then just kind of how that all looks in session. So, what does each session look like, and what should I anticipate, and what should I, be talking about and looking for? And then what I thought I would do is, after I kind of go over the explanations of how to really do ERP and do it well, I have kind of 2 options. I have 3 case studies that I have ready to kind of talk about, but I actually thought that it might be more beneficial and worthwhile to spend some time doing discussion and questions. So if you guys have any cases that you have questions about, consultation, just general questions, I thought we could leave a fair amount of time for that. If for whatever reason no one has any questions or no one wants to bring anything up, I can kind of fall back on the 3 case studies that I have prepared, if that would be more helpful for you guys. So either way, I think it'll be nice to spend the end kind of talking practically about cases. So just to review from last time, we talked about OCD, just the basics. So I will give you my kind of spiel on OCD and what it looks like. And when I talk about psychoeducation, as far as kind of what goes on in the room, so to speak, this is kind of what I use when I'm explaining it. So you can kind of take this and use it with your clients. I think it's the way most people probably describe OCD, but basically the way that I describe it is, obviously there are obsessions and compulsions, right? Obsessions are intrusive, distressing, unwanted thoughts. Oops, I'm sorry. Intrusive, distressing, unwanted thoughts that kind of come in, they get stuck. And as they get stuck, the person kind of spins around and the anxiety gets higher and higher and higher, right? Once the anxiety gets to a certain point, there needs to be some sort of compensatory behavior that happens to bring the anxiety down, right? And that's where your compulsion comes in. So the example I usually give for people that's really easy to understand is the hand washing example, right? You touch something that feels contaminated. You worry that you're going to get sick. You start having these obsessions. What if I get sick? What if I die? What will happen? Your anxiety goes up and up and up. A way to decrease the anxiety is to go to the sink and wash your hands, right? The tricky thing about all of this is compulsions don't work, right? If they worked, we wouldn't see people in our office, right? Because if you had the obsession, you did the compulsion, and great, everything is fine, and you're able to go about your day, that would be that, right? But the reality is that the compulsions don't work. So what happens is you need to do more and more compulsions to get less and less relief. So by the time someone shows up in your office, they're washing their hands 2, 3, 4, 10, 20 times with less and less relief. A lot of times people will wait until they get to the point where the compulsions stop working entirely. And that will happen, right? So I talk to people a lot about that who are kind of resistant and hesitant to treatment, that eventually these compulsions, which are working not so great for you anyway, are going to stop working entirely. And that's something to kind of be on the lookout for. OCD is all about the intolerance of uncertainty, right? So we deal with uncertainty every day in our day-to-day lives, right? You guys all signed on to this webinar assuming that we would show up, assuming that the guys from Newport would be here to introduce, assuming that I would be here to present. It's a good assumption. It makes sense and it's reasonable to suspect, but you don't know that it was going to happen for sure. You might have signed on and the link maybe would have been down or not working or whatever, right? You guys get in your car, probably not so much anymore when you're commuting home. You know that there's a chance in the back of your head that you could have a car accident, right? There's that uncertainty. It's not such a difficult uncertainty to tolerate that you're not able to get into your car and feel relatively confident that you're going to get home and make it home okay. But there is that uncertainty, right? We deal with that uncertainty all the time. The difference for people with OCD is that they are intolerant of that uncertainty, right? So the idea that, they might get into a car accident when they get in their car is just intolerable, right? And so obviously it relates to whatever symptom that they're having, but it all comes back to this intolerance of uncertainty. And one of the ways I like to always describe it is the French call OCD the doubting disease, which I think is a really lovely way to think about it. It's just you doubt everything. You doubt your brain, you doubt your senses, you doubt everything, right? It's about process, not content. And what I mean by that is OCD symptoms look really, really heterogeneous, right? So some people might have contamination concerns about being dirty. Other people may have concerns about, offending God or doing something that's blasphemous. Another person might have intrusive thoughts about pedophilia. These seem really, really different on their face. And they are in terms of, the content, but the content's actually not important. So I always encourage therapists and clients to really zoom out and think about, okay, what is the process, right? The obsession is X, the compulsion is Y. How does that work? So behaviorally, you always want to be thinking about how do you zoom out and think about what is actually going on here, right? Rather than getting really caught up in the content. A lot of people will say, it feels really different. I don't know how to manage it. I would always encourage you to kind of pull back, think about obsession, compulsion, right? How does that work? How does that function? And then what's the function of the behavior, right? So when you're doing exposure, you really want to think about what's the function of the behavior. And I'll give you guys an example of, two behaviors that looked really similar, were really different in function and really kind of guided our treatment and how we treated these two kids differently. So I used to work at the McLean OCDI junior program, which is a residential program for kids with OCD. And we had these two boys on our unit at the same time who both had a lot of contamination fears, spent a lot of time in the bathroom. So, at their face, they looked exactly the same. They would go in the bathroom, close the door. We would see them 3-4 hours later, right? And so when we talked to both of them, it really seemed like, okay, both of these kids have contamination. They'll both be treated the same way, et cetera, et cetera. Talking more with them, what we actually found out is that one of these kids had a more kind of typical presentation of contamination, right? He was afraid of getting urine and feces on him because he was, just kind of more in that disgust category, just really disgusted by it, wasn't really afraid of getting sick, but just really, really in the bathroom, wiping until he felt clean because he was really, really concerned that he would just be contaminated. It would just be disgusting. He wouldn't be able to tolerate it. Kid number 2 looked exactly the same. Again, he went into the bathroom, closed the door. 3 hours later, we saw him. But kid number two really had more of a social anxiety presentation. And his issue was he would go in the bathroom and wipe and wipe and wipe because he was really, really concerned that he would get urine or feces on his pants. Someone might see it and make fun of him, and then he would be really humiliated and really embarrassed, right? So these two behaviors look exactly the same, but when we really distilled it down to the function, we treated them very differently, right? So the first kid we really took from that kind of traditional contamination standpoint, whereas the second kid, we looked at it from more of a social anxiety standpoint of like, what are other people going to think of me if I do have anything wet on my pants? So it's really important that you kind of look at the function, figure it out in order to treat it properly, because otherwise you might miss the mark a little bit. Okay, so I wasn't sure where to put this slide. I hope it's kind of in the right place where it makes sense. Feel free to let me know if it's not, but I wanted to make a note about pure O. And people have talked about this idea of pure O, and I'll kind of explain what this is, for a long time. And I take real issue with that name. First of all, I think that language really matters, and it's a really kind of misleading name. So basically, maybe I don't really know the time period, but I would say like 15, 20 years ago, we started hearing about this idea of pure O, right? So people who have purely obsessional OCD, right? So when this was initially described, it was like, okay, these people don't have any compulsions. These are intrusive, distressing thoughts that come in and they just obsess, 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 right? And so these are your people with your intrusive harm thoughts, your thoughts about pedophilia, your thoughts about homosexuality, all of those things that you would put under that pure O category. So the reality of pure O is that it's not really a thing. And the reason that I say that is because there is no OCD that exists without compulsions. It's just not how it works. There's always a compensatory behavior. Now, the difference is it may not look as behavioral as going to the sink and washing your hands, but it is compulsive and ritualistic in nature, right? You just have to look at things a little bit differently. So when you're looking at someone who has this presentation, sometimes they'll come to you and say, I have pure O. Sometimes it's just they'll come and say, I have intrusive thought OCD. What you're really looking for here are a couple things. You're looking for compulsions as avoidance, compulsions as distraction, right? Thought suppression, and rumination. And I'll go into that a little bit. So when you think about avoidance and distraction, it's pretty self-explanatory, but I'll give you some examples. So for example, someone with intrusive harm OCD, so those thoughts of what if I kill someone? What if I hurt someone? What if I, sexually assault a child? These people are doing a lot of avoiding, right? And it's really, really important for us as therapists to identify what the avoidance is so that we can help target that in ERP, because that's going to be the RP of their ERP, right? Their response prevention. So, for example, someone with pedophilia OCD may avoid playgrounds, may avoid other places where little children are running around. If they're parents, they may avoid diaper changes, they may avoid bath time, right? If it's intrusive thoughts about harm, they may avoid anything to do with, maybe if it's a specific person, right? So some people will have the thought about a specific person. So if it's, I might harm mom, they might find themselves avoiding mom, generally speaking, right? Another thing I always ask people is, how are you with handling knives, right? Can you go, if I asked you to go into the kitchen and chop some carrots for a salad, could you do it? Could you empty the dishwasher? And a lot of times these people will not be able to do that because they don't want to hold a knife, because they feel that that's going to trigger the thought, and then they might lose control and hurt someone. So you really want to be looking for avoidance in that area, and it could look like anything really, right? Like maybe this person avoids eating steak because they know steak requires a steak knife, right? So you're really looking for all of those areas of avoidance. You're also looking for distraction, right? When they have this thought, are they distracting themselves in some way? Are they, saying something to themselves? Are they doing some sort of mental ritual, right? So something like, I know I'm not a pedophile. I know this is OCD, or, I know I'm a good person, things like that. Thought suppression, just trying not to have the thoughts. And then I want to talk a little bit about rumination. So the idea of kind of trying to figure something out. So when you're talking about rumination, you're almost always trying to answer the question of, Like, what am I trying to figure out? So when you're working with a client, you're trying to figure out if it's rumination and they're telling you that they're kind of like obsessing about these thoughts. I always say, like, okay, well, what are you trying to figure out? You're trying to figure out if you would actually hurt a child. You're trying to figure out if you would actually hurt a person. Okay, so that's your rumination, right? And rumination is really a compulsion, right? So I think a while ago, we used to think about it more on that obsessive side. And then it was kind of like, well, there's nothing we can do about it. We don't want people to suppress their thoughts. So just there's nothing we can do. The way we're seeing it now is really as a compulsion, right? And the best example I know for understanding the difference between intrusive thoughts and ruminative thoughts, and I'll give some credit to where I found it, which is Dr. Michael Greenberg, who does a lot of this work, and you can go on his website. He has wonderful blog posts about rumination, but the way he describes it is the difference between an intrusive thought and a ruminating thought is the idea of, if I tell you guys not to think of a white elephant right now, you're probably all thinking of a white elephant, right? That is unavoidable, can't really do much to stop it, don't want to suppress it. If I put a math problem in front of you guys and say, okay, I want you to work through this math problem, and then halfway through I asked you to stop working through that math problem, that's kind of something that you have control over and you're able to start and stop at will, right? That's rumination. So while you can't suppress an intrusive thought, you can actually stop or move away or redirect a ruminative thought. So the other type of ruminating thought is mental checking. So kind of going through a checklist of all of these ways, or mental reviewing, that you may or may not be a pedophile, be a murderer, be homosexual, whatever the thought may be, right? So when you're doing ERP for this type of presentation of symptoms, the first thing that I always say is, like, you really want to like comb all of the behaviors for avoidance. Where is the avoidance taking place? Where's the distraction taking place? What are the mental rituals? Because there are mental rituals. Even if they say, like, oh, I don't do anything, I just have the thought, I don't do anything, they're definitely doing something. It's just a matter of kind of understanding how to pull it out of people, because there are going to be avoidance behaviors and there is going to be rumination in every case that I've seen that looks like this. So you want to do the same thing. Again, pull back, think about what is the obsession, what is the compulsion, and then engage in ERP in the same way you would with any other type of OCD. And I can get to more of that as we talk about ERP if it comes up, and if you guys have questions about it at the end.
Stacey, I'm going to interrupt you really quickly. I'm so sorry. Can you just repeat the name of the doctor that you got that data from? Somebody was asking, they didn't catch the last name.
Yeah. So it's Michael Greenberg. And you can just go on, if you Google, I think, Michael Greenberg OCD, he has a really nice website, and he writes a lot of blog posts that are just, I print them out for my clients all the time. They're short, they're sweet, they're in layman's terms, and they're great reading for people to just kind of understand what rumination is about. He also, if anyone is interested, there's a podcast called Ocd Stories, which I would strongly encourage you, if you're interested, to start listening to. It has really, really amazing people on it. And he has, I think, 2 episodes on that where he talks about rumination in more detail. And I'm seeing the question about, can a person have OCD without compulsions? And I think I covered that pretty much, but the answer is no. The compulsions just look different: avoidance, distraction, mental rituals, and things like that. So, and Kirsten, please interrupt me with questions. I think it's helpful to do in the moment. So,
okay, perfect.
The process of ERP. So kind of what does it look like? First session or 2 is basic, psychotherapy 101, intake, rapport building, all that kind of good stuff. Therapeutic alliance is really, really important in this, and all therapies, but you really want to have someone who trusts you. You're going to be encouraging them to do really, really hard stuff, and they need to trust you both as a human and as an expert. So that's really, really important. The next piece is psychoeducation. You want to spend a really good amount of time on the psychoeducation piece. It's really, really important. You want people, again, to trust you, to know what they're doing. If you're going to ask them to do really hard things, they're going to have to know why. And so there has been a couple of times in my experience where people have come to me in a lot of distress, and they kind of say to me, like, I don't want to spend too much time on this. I really just want to get going. I don't really want to do the hierarchy. Let's just start on the exposure. I kind of know what it's about. And there's been a couple times where I've kind of gone along with that just because they seem to be in so much distress. And I have to tell you, it never ends well. So really spend the time doing psychoeducation. Don't skip past this. Don't just brush by it. It's really important. So you really want to be talking about ERP in terms of, so first of all, that kind of OCD definition that I gave is kind of always where I start. And then when I talk about ERP, what I want to be talking about is learning, right? We're learning a new skill. There was, and in my last presentation, I talked a little bit about it, so I won't belabor it, but we used to focus a lot on habituation of anxiety. Now it's really more about learning and tolerance of uncertainty, right? So the anxiety may go down, it may not. The intrusive thoughts may disappear, they may not. That's really not the goal. It's a happy byproduct and it happens for a lot of our clients, but it's not the goal. The goal is really to be able to tolerate the uncertainty that comes along with OCD and to be able to kind of live your life, right? To learn a new skill and be able to kind of do the thing that's making you anxious, right? And then I like to talk about the cycle of avoidance and how avoidance really reinforces the symptoms of OCD, right? One of the best examples of avoidance is, it's more of a social anxiety example, but I think it kind of makes this point well, is the idea of, you get an invitation to a party, we'll say pre or post COVID, you get an invitation to a party and you want to go, but you're really feeling anxious. And as the days go by, the anxiety builds and builds and builds and builds. And the day before the party, you pick up your phone and you text the person who's throwing the party and you say, listen, I'm really sorry, but I can't come. What happens to your anxiety? It plummets, right? It goes right down. And so what that teaches us is that the next time that you're invited to a party, your brain is kind of saying, well, it's going to get so much better if you just say you can't go. Just say you can't go. You'll feel so much better. The next time that you say no to that party, every time you do it, it kind of reinforces that idea of avoidance. It makes it easier to avoid and it makes it harder to approach. And so you really want to talk about the idea of avoidance and how it maintains OCD. And so really the goal here is we're going to stop avoiding the things that make you anxious. We're going to allow them to be there. We're going to allow ourselves to sit with uncertainty around, could this thing happen, right? And I know, especially for new therapists, for family members, the urge to give reassurance around like, oh, it's going to be fine. You're not going to be embarrassed. You're going to go to the party. It's going to go great. You're going to have fun. That urge is really strong. And as a new therapist, you have to really kind of watch yourself and notice when you do it and kind of course correct as you do it. The big ones, the kind of obvious ones, are easy to kind of modulate, but then there's some sneakier ones where you'll find yourself reassuring and not really realizing it till after. But really be on the lookout for reassuring your client. It happens a little bit in the beginning and it's not a huge deal, but you really want to taper it off pretty quickly. And you really want to have an upfront conversation with your client about what reassurance does. And reassurance also, I forgot to mention that in my Pure O slide, but reassurance is another form of ritualizing, where, you're asking someone. So someone who has a fear of getting sick might say, are you sure that chicken I ate was okay? Are you sure it was cooked all the way? Can you look one more time and just make sure it's not pink in the middle? Are you sure it's okay? I ate it. I'm feeling a little queasy. Can you just let me know what to do? So you really want to work on the way that I frame reassurance is, you want to be honest, essentially. Right. And so there are some therapists who will say to you, like, I don't know, you're probably going to get sick. And I don't usually take that tack. I mean, you can, but I don't know what purpose it serves. Generally, what I say is be honest with the person, right? You probably won't get sick. The chicken is probably fine, but I just don't know. Right. And that's the honest truth. I don't know if you're going to get sick from chicken. Another thing that I say, especially to kids with magical thinking, if I don't knock on wood, what if my mom dies in a car accident? And so my response is generally something along the lines of like, I really don't see how those two things are related. And I'm not sure that could happen. But the honest truth is, I don't know how the universe works. There's a lot of things about the universe that I just don't understand. And so I can't give you 100% certainty that that's not going to happen. I don't think it's going to happen, but I really don't know. So that's kind of the road that I take with regards to reassurance. I think it's helpful because you don't necessarily want to push them in the other direction of it's definitely going to happen, but you don't want to say that it's not going to happen. So you want to kind of like sit on the fence where you're like, I just don't know if it's going to happen. Probably not. You're probably not going to get sick, but you could, right? For maybe a social anxiety example, it's like, well, maybe that person thinks I'm stupid. Well, maybe they do, right? That's kind of an unknowable thing. And they probably don't. I mean, you're an intelligent person, but we really don't know. And we never will know because we can't get into somebody's head, right? So you really want to hammer home that psychoeducation. It's super, super important that they understand why they're doing the ERP. And I'll get into that a little bit more when we talk about ERP, how to explain it to people. The next thing that I do, and I'll add to because I don't think I didn't write it in, but is the assessment. So, and we talked about this in the last presentation, doing the SIBOX or the YBOX, which stands for Yale-Brown Obsessive Compulsive Scale, or Children's Yale-Brown Obsessive Compulsive Scale. And that's a really great, albeit long and a little bit unwieldy tool for getting a lot of really good information about OCD. So I would also put that in that kind of rapport building assessment phase. Your next area that you're going to work on is building a hierarchy. So I'll give you a little bit of insight into the way that I build a hierarchy. I usually frame it as, this is going to be a brainstorming session between you and I. I'm going to start you off. I'm going to help you because I know you're not really familiar with how to set up an exposure. So we'll do that together. What I do is I usually pull up just a Word document, or on Zoom, sometimes I will screen share and just pull up a Word document. And I'll actually refer back to their SIBOX or YBOX. I'll look down the symptom checklist and I'll just start like throwing some ideas out there. Okay. So the way you want to frame the hierarchy is, this is a list of exposures, right? It is a document that we're going to refer to, not all the time, but sometimes. And it's going to give us a place to start for exposures. Now, the thing that you want to tell clients is like, this can be overwhelming, right? Because really what we're doing is we're putting all of your fears, all of your anxieties in one place. So even just talking about this could be overwhelming, and that's okay. We're not going to get to it all at once. We're going to start small. We're going to start slow. And the other thing you want to let them know is that this is all based on their own willingness. So there's nothing on here that I'm ever going to force them to do. I may encourage, we may work on motivation, but I'm never going to force, right? So we can put it on there, but if you decide you don't want to do it, that's okay. And then the other thing to remember is that, we're working on I work on a 1 to 10 scale. Some other therapists do a 1 to 100 scale, as far as how anxious doing this thing would make you. And so we call that subjective units of distress, or SUDs. So I'll say, if we were to do X, what would your SUDs be? So there's going to be things that you're going to bring up to clients and they're going to say, well, I would just never do that. That would be just something I would never be willing to do. So I always put it on the hierarchy anyway. And usually I just put 10 plus, because the reality is, and I usually explicitly say this to clients, the reality is that you may get halfway through treatment and something that would be a 10 plus, you may look at now and it's only a 6 and you'd be willing to try it. So let's just put it on there. You may never get to it and that's fine, but we might also get to it and that would be great. So you really want to build a hierarchy where you have a lot of different types of exposures at a lot of different levels. So when I say levels, I mean levels of anxiety, right? So I'll throw a couple things out right off the bat to someone. So I might say to someone with contamination, if I was to ask you to touch the table without washing your hands, how high would your anxiety go? If I was to ask you to, pet the dog and not wash your hands, how high would your anxiety go? If it was more of an intrusive harm thought, I might say something like, if I was to ask you to, go in the kitchen and cut a fruit salad with your mom, how high would your anxiety go? And you have to remember that within this hierarchy building, you want to be thinking about the response prevention, right? So you might even explicitly say to someone, if you were to hold a knife and allow yourself to think about the idea that you might kill someone with it, right? Rather than saying, hold the knife and try not to think about it, or hold the knife and, because a lot of people will come into your office and say, listen, I don't think this is going to work because I do exposures all the time, right? I'm scared to go to school. I go to school. I'm scared to touch things. I touch things. I do exposure all the time. It doesn't work. Generally, what they're saying to you is, I do exposure all the time, and then I ritualize the heck out of it afterwards. So really what they're doing is the E, but they're not doing the RP. And what we talked about last session was that the RP is way more important than anything else, right? So what I always say is, it's awesome, first of all, that you're approaching these things and that you're exposing yourself to these things. It's super, super important. But we need to also be working on the RP part, right? Because if you're not, I always describe it as like running on a hamster wheel or running on a treadmill, right? You're working really hard, you're going really fast, and you're getting nowhere. You're not getting better, right? So it really needs to be about doing the exposure without doing the RP. So, Kirsten, was there a question?
Yeah, somebody was just wondering if you could repeat the names of your preferred assessment tool.
Sure. So it's the Y box. It's YBOCS, and it stands for the Yale-Brown Obsessive Compulsive Scale. And the children's one is just the Psy box. It's just Children's Yale-Brown Obsessive Compulsive Scale. And you can find them on the IOCDF for free. So you just go, usually what I Google when I pull it up is like Y box IOCDF. And it comes up in PDF form, and you can just download it and print it. Okay, so hierarchy building, you want to really get as many items on that hierarchy as you can in as many different domains, right? So you want to kind of cover all of the symptoms as best you can. Really kind of get, and remembering that all exposures are scalable, right? And what I mean by that is, if it's too difficult, there are ways to scale every exposure back. And I'll give you an example that I'm actually going to steal from one of my case studies if we get to it, but I think it's probably one of the most stunning examples of scalable exposures that I have. So I'll use it. I was seeing a client who had a lot of fears of contamination and just disgust around toilets, right? So everything she did, she was fearing that she would be accidentally touching the toilet, more specifically that the toilet would be touching her hair. And I mean, these could be situations where she was nowhere near the toilet and she would have these concerns. So when I first started seeing her, the idea of her going into the bathroom, even going near the bathroom, was completely unheard of. She just could not do it. So when you get a client like that and it feels like you're getting stuck right away before you've even started, you have to scale back. And sometimes you have to scale back way, way back, right? So what we ended up doing for our first couple of exposures was my office was right across the hall from the bathroom, the restroom. And so basically my office door was lined up with the restroom office door. So it was kind of a straight shot. So I would have her sit against the wall in my office. I would open up my office door and I would open up the bathroom door. So she was probably, I would say, about 10 feet from the toilet. And I would just have her sit there and look at the toilet. And she would have these thoughts about, oh my God, what if my hair touches the toilet? What if my hands touch the toilet? What if I'm dirty? What if I have feces on me? And the idea was just, okay, we're going to sit here with this thought. We're going to think about, again, I think the likelihood of you being able to touch the toilet from 10 feet away is very, very low, but I don't know, maybe, right? And then most importantly, we're not going to wash our hands. No matter if we feel contaminated, if we feel dirty, we're just not going to wash our hands. So we did that for quite some time. The next step was really like we moved the chair to the closer side of the office and had her look at the toilet. And I had her stand in the doorway of my office and look at the toilet. Then in the doorway of the bathroom and look at the toilet. And we just had her keep approaching that until she was actually at the point where she was touching the toilet. And now she's really able to use any bathroom at any time, which is really, really great. So after you finished your hierarchy building, that's when you really want to start your exposure. And realistically, at that point, your sessions just become all about exposure. So generally speaking, the session might look like, you come in, you talk about homework, you talk about what happened over the week, you set up your exposure, you do your exposure, and then you set up your homework for next week. So that's really what the structure of the sessions look like. And, one of the concerns I've heard from a lot of new therapists is that there's just not enough time to do all of that in one session, one 45 or 50-minute session. And it's just not true. There's plenty of time to do that. Exposures don't have to be extraordinarily long. Back when we worked on more of a habituation model, we did do 90-minute sessions and we spent a lot of time in exposures. And it's not necessary like we thought it was. I do exposure sometimes with people that last 5 minutes. I do exposure sometimes that last 30 minutes or 40 minutes, but really it's the idea that you're exposing yourself to something and not ritualizing. You don't need to habituate. Start small, get some success, make sure the client is doing it correctly. I would say that on your end, troubleshooting with the client, making sure they're doing it correctly is the most important thing. On the client's end, it's really, really important for them to see like, hey, this does actually work, right? If you work on really, really hard things right away, you may not see that success right away. Conversely speaking, if a client is really willing and really wants to do something hard, because it's so impacting their lives, I will go along with that. I will join them in that and say, okay, let's start there then. If they say to me like, school is the hardest thing, but it's also the thing I really, really want to get back as quickly as I can, then great, we'll start with school. Same thing with family, right? I kind of let the client guide that and guide the treatment in that way. Because then they feel like they have some agency, they're using their willingness. But the really important thing on our end is to make sure they're doing it properly. And then working on generalize, you want to really have them generalize it to all areas of their lives, right? I always say to clients, you see me like 1 hour a week. There's a lot of hours in a week. If you're doing great exposure work in my session and then nothing else for the rest of the week, it's just not going to take. It's just a numbers game, right? 1 hour versus however many hours there are in a week. It's just you can't, it's not going to work. So you really need to be able to do these things anywhere, anytime, under any circumstances. A lot of clients will say to you, well, I can't do the exposure under these circumstances. I have a class right after this today. So I can't do exposure in session today because I'm really worried that I'll be too anxious to go to class. And you really want to kind of try and stop that behavior, because then you're basically, if you agree to that, then you're basically agreeing that things are too hard and they should be avoiding things. And we don't want to do that. So I always say to people, like, I want you to be able to do these exposures with blindfolded, one arm tied behind your back, under any circumstance, in any place, way, shape, or form, right? And the clients that are successful are the ones who will come back and say to me, I had the situation where, I was really, really anxious and I didn't want to do it, but I did it anyway, right? And that's not even homework that we assigned. I just did it anyway because I knew it was making me anxious and I knew I should. Those are the clients that's an indicator to me that these clients are going to get much better. And then homework is just part of the generalization. So, homework should be something that is not super arduous. They shouldn't be spending hours a day doing it because then they're just not going to do it. But it should be something that they can take with them and practice throughout the week, and come back to you and tell you how it went, right? In the beginning, it might be awareness exercises. So just noticing what OCD thoughts you have during certain situations. A lot of times I'll ask people to kind of jot down when they're noticing their OCD symptoms, just to get a better idea of like when they're happening in real life. But then once you really get into the meat of exposures, you really just want to start assigning exposures for homework. And people should be doing exposures all the time during their life. Kirsten, I'm seeing the Q&A is getting a little filled up, but I'm not looking at it. Do we think it makes sense to?
So we can take a look really quickly. Deborah had a question in regards to the what if questions. Would you suggest not addressing them directly? Meaning, what if I do get sick from the chicken? How would you suggest, or would you suggest not then asking what getting sick would mean? Sorry.
I'm not sure I totally understand the wording of that, but I think what it's saying is like just how, so I would just say, I don't know. What if you do get sick? What would that look like? Right. And then you can kind of dive a little bit more into like what the fear is. But yeah, I would say, what if you do get sick? What if this does happen? What would be, and then you can kind of leave it at that. There's not a whole lot after that, I think, to say, if they say, well, then I would throw up. Okay, then you would throw up. Well, then I might need to go to the hospital. Yeah, maybe that would be less likely, but it's a possibility. And I would probably just leave it there.
Thank you. Mm-hmm. There was another one here from Amy. Do you find that there is a high correlation between bathroom obsessive compulsive behaviors and a history of sexual abuse?
No. I don't know the research, so I'm not going to speak intelligently about what the actual rates are. Certainly there is, it does happen that there's a history of sexual abuse, and that can, so let me back up. There certainly are a group of people with OCD that have had a trauma incident that causes or worsens the symptoms of OCD. That is absolutely something that happens. It's why a lot of us are also trained in PTSD work. So it does happen, and the trauma situation will have to be resolved and processed really before, in my experience, before the OCD stuff will get a lot better. I would really say the large majority of people with bathroom obsessions and compulsions do not have a history of sexual abuse. But again, I don't know what the actual research and numbers are. But I don't think that it's something that, I guess what I want to say is that when we see someone with OCD related to the bathrooms, my first thought is certainly not, was there trauma? We always ask about trauma in the intake. And there are times when it certainly will present itself during treatment, but it's not my go-to if I see this type of OCD.
Thank you. And then somebody just asked to clarify on the rumination versus intrusive thoughts. So the rumination can be stopped and the intrusive thoughts cannot be stopped. Is that correct?
Correct. Yes. So intrusive thoughts, they come in, they're quick. It's like, so the intrusive thoughts are the initial thing, right? And really everybody has intrusive thoughts to a certain degree. What happens next is whether or not it's OCD, right? So if you really pay attention to and get stuck and start ruminating on the exposure, or not on the exposure, I'm sorry, on the intrusive thought, that's when it kind of becomes OCD. And the idea of rumination is really, again, something that's voluntary, right? So another example of kind of ruminative or being able to stop a thought is like, if I asked you to plan a vacation, to work on an itinerary of a vacation, and then I said to you, okay, I know you're thinking really hard about this, but I actually want you to shift your attention and do something else, you could do that, right? Rumination is the same thing. So if you're trying to answer a question, solve a problem, that's probably rumination. And that, yes, you can redirect your attention. You can say, okay, I'm going to stop ruminating now.
Thank you.
Dr. Dobrinsky, if I could ask, and Kirsten, not to cut you off, I want to make sure we don't lose this one in the chat. There was an individual that asked, what would exposure therapy look like virtually?
That's such a good question.
Yeah, especially in this day and age.
Different, but the same. So realistically, it looks the same. I mean, you do the same things. There's pros and cons to doing exposure virtually. The pros are we can get into the person's home. We can get to the things like in the moment that the person is really experiencing, right? So, to give you an example, the girl that I mentioned that I was working with her toilet, she has recently had a little bit of a relapse, and we've been working virtually, just doing some like booster sessions every once in a while. And she's in her room with the bathroom that she's had such a problem with. And so it's great because I'll say to her, all right, put the laptop down on your bed and point me into the bathroom. And then I want you to go into the bathroom and touch the toilet and then come back and let's talk about it. So it's really great for that, the in vivo exposures that we can do in session in the person's home or wherever the case may be. It does make it a lot harder because, there's not that. I think one of the hardest things about doing virtual exposure therapy is you can't be joining the client, right? So one of the greatest things about exposure therapy is I'll do it with you, right? I'll touch the floor, I'll do the thing, I'll hold the knife, whatever. When someone's on the computer, obviously that can't happen. But really, other than that, it looks the same. You have to get a little bit more creative, but it's pretty much the same.
Thank you.
Yeah. All right, I'll keep going. Okay, there it goes. So this is an old slide from the first presentation, just to kind of go back over what exposure response prevention looks like. So again, the exposure kind of hangs on the obsession piece, and the response prevention is related to the compulsion. So when you're doing psychoeducation, the easiest way to describe exposure response prevention is I'm going to have you, or you're going to be exposed to an obsession that makes you anxious, and I'm going to prevent, or you're going to prevent doing the ritual, the compulsion, whatever the response is. That's it. That's what ERP is. It's obviously a lot more nuanced than that, but that's kind of the one sentence definition, right? The RP, the response prevention, is the most important piece of ERP. Because again, clients are going to come into you and say to you, listen, I do this all the time. It's not working. Well, it's not working because you're probably not doing the RP. You're probably just doing the E. So I always say, like, it's more important to do an easier exposure and a full RP than to do something harder where you have to ritualize after, right? If you're doing an exposure and the only way you can do this exposure is to ritualize after, then that exposure is just way too hard. So as a therapist, if a client is coming to you and saying, like, I did what you asked me to do, but I had to wash my hands for a half hour afterwards, that exposure was too hard. You need to pull it back and you need to do something easier, right? The other thing I always say to clients is really there's 3 ways to do RP, right? So the first way is the most kind of ideal way is just to not do the ritual, not do it at all. The second way is to delay it, right? So you may say, okay, I'll do a lot of exposures with clients, especially related to contamination, where they touch something and I'll say to them, okay, how long can you go without washing your hands? And a lot of times what we'll do is I'll say, can you wait till you get home? And this was, back in the day of in-person therapy. Can you wait till you get home to wash your hands? Great. So you have a 15-minute ride home. You're going to wait until you get home. You're going to walk in the door. You're going to say hi to your cat, and then you're going to go wash your hands. So you can delay. The third thing you can do is mess up the ritual, right? So if OCD is saying that it wants you to do it a certain way, it wants you to do something until it feels just right, you have to do something 6 times or 8 times or whatever the case may be, can you do it until it feels not quite right? Or can you do it 5 times instead of 6? Or if OCD is telling you to do it a certain way, can you do it something slightly different, right? So any way that you're messing up that ritual is helpful. Obviously, the goal being eventually removing the response altogether, but sometimes that's just not possible. So I've done resisting where we'll resist a ritual for 10 seconds, 15 seconds, and then we just space it out, right? Can you resist the ritual for 30 seconds, a minute, 5 minutes, whatever it is? And really being upfront with the person that we're going to work on resisting for longer and longer periods of time. No relaxation training during exposures. This is, I think, one of the biggest mistakes that new therapists make. Relaxation training has really no place in OCD work, period. So you really should never be doing any relaxation. You really want to have them sit with the anxiety, just be with the anxiety, allow it to be there. Clients ask me all the time, maybe the biggest question they say to me, but like, what I don't understand is, what do I do? Like when I'm anxious, what do I do? And I always say, nothing. You do nothing. It's a very, very unsatisfying answer to give people, but it's the right answer, right? You don't do anything. You just sit with the anxiety. Do not have them do any relaxation training. Really be mindful if they're trying to distract themselves, if they're trying to avoid during the exposures. You really, really want to look for that. And you really want to explain how that actually functions as a compulsion and is something you don't want to do, right? So again, looking for hidden compulsions. So you're looking for the avoidance, the thought suppression, the mental rituals. And mental rituals can look really like anything. There's a lot of checking, a lot of mental reviewing. So, people might go back and kind of mentally review conversations they've had with people to see, does this mean I'm a bad person? Or did I say something that that was wrong, or that made that person feel uncomfortable? Or did I do something that would suggest that I was a pedophile? And kind of going back and mentally ritualizing. These are really, really important things to bring up with clients. And I think therapists sometimes are not afraid, but are hesitant to bring up these mental rituals because they can sometimes be uncomfortable. One that we see a lot with clients who have intrusive thoughts around harming children is checking their genital areas for arousal, right? So they'll be at the playground or they'll be with a kid and they'll say, oh my God, did that arouse me? And then they'll kind of focus their attention on their genital areas. And what we always say to clients is like, if you focus attention on any area, you're going to notice more sensation, right? And so then they notice more sensation. And then that feels like, confirmation that they are pedophiles, and then they become more anxious, and then they check back again, and then they notice it more because they're focusing more attention on it. And so you see how that cycle can kind of work. And then for kids, a lot of parent and family training around accommodation and reassurance seeking. Actually, I shouldn't say kids, families in general. I always offer, I don't know if other therapists do this, but one thing that I always offer is, you have kind of a free pass to have people come and sit in session if they need psychoeducation. I've had boyfriends and girlfriends and partners, and I've even had every once in a while a close friend will come in, a roommate will come in and say, I don't know how to handle this. Like, I just need some information. So I always offer that, like, please have your parent, whoever you live with in the home, come in. The large majority of people are inadvertently accommodating someone with OCD. And so teaching them how to not accommodate, how to not provide reassurance seeking, the more we can kind of get the family wrapped into this, the better. So optimizing ERP, this is another slide that I had in the first presentation, so I won't spend a ton of time on, but developing a strong therapeutic relationship. I wouldn't ask you to do anything I wouldn't do myself. So this kind of goes back to some of the Zoom exposures. How do you do exposure online? It's harder, but really you should be willing to do anything that the client is willing to do. So if it's something that, a lot of therapists, a lot of OCD therapists will kind of see how far they can push a client. But if you're not willing to do it, you really can't ask the client to do it. So you really want to say, like, we're in this together. I'm not going to ask you to do anything I wouldn't do myself. And, this is the way we'll do it. This gets tricky when the therapist has their own anxieties or own things that they don't want to do. And, you kind of have to be aware of that and see if you can challenge yourself. And the reality is also, the longer you're an exposure therapist, the more things you're willing to do, right? There are a lot of things when I first started out that I wasn't really too keen on doing that now I do, probably without even any hesitation. I'm thinking specifically about more social type exposures where the theme or the risk is embarrassing yourself and going into stores and doing silly things or asking stupid questions. And I think initially that was really hard for me. And now it's very hard to embarrass me. And I will pretty much ask any stupid question along with my client because, exposure works for everybody. You don't have to have OCD to be able to benefit from exposure. Stacking exposures is really important. So, doing things that are, I have an example of this more than explaining it, but taking more than one exposure and doing it at the same time. So I'll give you an example of a client I'm working with right now. He has a lot of existential OCD, a lot of concerns about, whether or not people are actually kind or whether or not it's just a learned behavior. And he gets really caught up in that. And then he also has some harm thoughts. So worries that he's going to stab someone. So something that we might do is I'll have him read an article about, about the thought about whether or not we're born kind or whether we're taught kindness. And I'll have him do it with a knife sitting next to the computer or a knife sitting next to the article. So that way he's kind of doing two different exposures. It just really kind of deepens the learning around exposure. Expectancy violations, which is just the idea that you're expecting something to go one way and then it goes, maybe it's easier. So maybe you say, okay, this exposure is definitely going to be an 8, and then it turns out to be a 4 or 5. I always really make it a point to be really explicit about, like, I want you to really think about that for a second. You thought it was going to be really, really hard, and it really wasn't that hard, because really what that does is that also kind of deepens the learning, right? Whenever there's that violation of what we think is going to happen, it deepens that learning process. Removing all safety behaviors. So you don't want anything lingering. You don't want the kid with the Xanax in their backpack that they have there just in case, even though they're never going to use it. You don't want the kid to be the one that always drives. And I always say kids, I'm sorry. I obviously work with kids, but I mean everybody. You don't want the person to be always the one that drives everywhere in case they need to escape, right? Those types of safety behaviors, we really want to remove all of those. We really want to look at those as kind of ritualistic as well. Occasional reinforced extinction. This is the idea that every once in a while the feared outcome might happen, right? So if you think about maybe someone who has a fear of vomiting, right? Maybe they get sick and they vomit. Don't panic. A lot of therapists will say, well, the exposure is trying to disprove that this thing will ever happen. No, the exposure is trying to get you to a place where you can tolerate the uncertainty of whether it'll happen. Occasional reinforced extinction actually is not a bad thing and can be beneficial to treatment. So if something happens, if they come to you and they say, oh my God, I ate chicken and I did get sick, see? Okay, well, that's a chance. Just like we said, we never said it definitely wasn't going to happen. We said there was a chance it could happen, and it did happen, and that's okay. And then engaging in exposures across multiple contexts. So just in as many environments, again, doing those exposures in every place, setting, et cetera, et cetera.
Can we pause quickly for a couple more questions or? Okay. So back to, I think 2 slides ago, we had a question about the relaxation and somebody's asking, why is it not good to teach relaxation?
Because it's a really good question. Because relaxation is in the situation, it's another form of compulsion, right? It's another form of avoidance. You're trying to relax so that you're not actually engaging with a thought, right? The goal of exposure response prevention is to allow a thought to be there and allow yourself to sit with the anxiety that comes with it rather than trying to erase it, right? And so relaxation training is really a way that we try and erase the anxiety. And the goal of ERP is to teach us that we're able to tolerate and sit with uncomfortable feelings. So the goal is to allow and be, noticing and non-judgmental towards any thought and feeling that comes up without attempting to change it, right? So that's really one of the things that, especially when you kind of add, I do a lot of ACT work in kind of conjunction with ERP, so a lot of the acceptance and commitment. So the idea is really allowing, so this is kind of hangs on that mindfulness piece, allowing the thoughts to be there, noticing whatever shows up and not attempting to do anything to change it. That's really the point, is that you don't want to do anything to change the thought. You just want it to kind of be there, sit there, and any kind of relaxation, anything that you're doing to artificially remove anxiety is going to backfire, right? That can be kind of thought of as a compulsion in the moment, right? Now, I say to people a lot, like if you're in a situation where you can't sit with anxiety because you just can't, right? Like say you're taking the SATs and you're having a panic attack, it's not necessarily the time to say, okay, I'm going to treat this as an exposure and allow myself to get up to a 9 or 10 and not take the SATs because I'm just sitting with my anxiety. In that moment, it's not really realistic to do that. And if you need to do a little bit of relaxation to get yourself through that, that's okay. But I would say that above all else, relaxation training is not beneficial in exposure. You don't want to do anything to artificially remove the anxiety.
Awesome. Thank you so much. Somebody was also asking if you could just quickly repeat the definition of ERP. I think that was also from the previous slide.
Yeah. So it stands for exposure response prevention. And the easiest way to describe it is you're exposing yourself to an obsession, you're exposing yourself to an uncomfortable thought, allowing your anxiety to be there, and resisting doing any kind of ritual or compulsion or any kind of response.
Awesome. Thank you. He had another one about, is it possible to do imaginal exposures in sessions, specifically in social exposures or situations?
Yeah, absolutely. So that's a really good question and something I didn't really cover in the presentation. But there are kind of the 2 types of exposure, the imaginal and the in vivo. So imaginal is basically exactly what it sounds like, imagining a situation that could happen. So for that, we use a lot of script writing. So actually writing down the feared outcome or what might happen and having the person read it. A lot of times now we'll have the person record their voice and they can listen to it. So, if they are socially anxious, and that really works with multiple contexts. If they're socially anxious, maybe having them, like I had one girl that worked in the city. And so I would have her, she recorded a script on her iPhone, and then she would sit on the subway and listen to the script as she was on the subway. So the imaginal exposures are great. I think in vivo is usually preferable because you're able to really be in the situation. A lot of times people will say, well, for the intrusive, distressing thoughts about things like pedophilia and, harm, the imaginal exposures are pretty important. Obviously, we're never going to do something that's dangerous to someone or some other person, so we're not ever going to actually harm someone or anything like that. So scripts are helpful for that. I find also with intrusive thoughts, intrusive harm thoughts, really the RP is where you should be focusing, right? So if, you want to do an in vivo, people would say to me like, well, how can you do an in vivo exposure with someone that has intrusive pedophilia thoughts? They're not going to have them sexually assault a child. Well, of course not. And that's not really what it's about, but you are going to have them go to places where, children are and not engage in any checking behaviors. So some examples are like, I've taken people to the movies. We'll go to see a kids movie. Sitting in a dark room with lots of little kids while watching a kids movie is very, very hard for someone with intrusive pedophilia OCD. Like I said, going to playgrounds, babysitting nieces and nephews, changing diapers, things like that. So those are all in vivo examples. But yes, imaginal exposures can be helpful. I think usually they're a nice gateway into exposures if someone is too anxious to do an in vivo exposure.
Thank you. I'll do one more and then we'll do the rest at the end because I want to make sure you have time to get through everything too. But is it helpful to model the exposure behavior for a client, or would that be counterproductive?
I'm guessing the person just means like doing the exposure and showing what it should look like. I think that's super helpful. I definitely think that modeling is great. And, it's not a bad thing to say, this makes me feel a little uncomfortable too, or I'm kind of grossed out by this exposure also, and kind of normalizing that. And, there'll be a lot of times where I'll say to people, I really don't want to do this exposure, but I'm willing to do it because I think it's important and I value you getting better. And so I'm going to allow myself to be uncomfortable, just like I know you're going to be.
Perfect. Thank you. There's a lot of other great questions in here, but I'm going to let you keep going and we'll get to them at the end. So
that's good, because I think I only have another couple slides, I think, so maybe we can just spend the rest of the time on questions. That might be more helpful.
Perfect.
So common new therapist mistakes, I think it's really important to kind of go over these. So not going far enough, right? Therapists, and especially new therapists, will sometimes feel anxious about talking about certain things. As an exposure therapist, you get really, really comfortable having really uncomfortable conversations about, what goes on in the bathroom, or, sexual stuff, or things that you never thought that you would, talk about in the course of your day at work, how many times you wipe and what that looks like, and all of these weird things. By not going far enough, by not being willing to really ask these questions and find out what's happening, you really risk. I had one presentation that I went to a long time ago where the speaker kind of compared it to the idea of like someone having a tumor and the surgeon going in and taking out 95% of the tumor and then just letting the 5%, leaving the rest of it in just because like it probably will be okay, right? No, a doctor would never do that. They're going to remove the whole thing. And so you really want to go as far as the client is willing to go, right? And so a lot of times when, people have a lot of bathroom compulsions, like we will sit down and I will get out a piece of paper and we will make a list of every single thing that happens from, time you walk into the bathroom until time you walk out of the bathroom. You really have to be willing to do exposures that seem kind of gross, right? Eat food off the floor, touch the toilet, do things that really are kind of above and beyond. And the example that I always give, because people will say to me, why do I need to do these really gross things? And the example that I always have at the ready is I remember at one time I was at work and I went and used the bathroom. I forgot I had my phone in my back pocket. And some of you guys probably have had this experience. I went to go to the bathroom and my phone fell in the toilet, right? And I had to make a choice at that point. I had to decide, well, I don't know. I either leave my phone in the toilet or I take a deep breath, stick my hand in the toilet and pull my phone out. It's not a situation that I ever hoped to encounter. It wasn't something that I was enjoying and sticking my hand in the toilet, but sometimes life is gross and we need to be able to handle situations that are kind of above and beyond what we would normally handle. And so the idea that you can do something hard and not have it ruin your day, right? I picked my phone up out of the toilet. I cleaned it as best as I could. I washed my hands and I kind of moved on with my day. We want you to be able to do these hard things when they come up without falling apart, right? That's the reason maybe we go further than you would think is necessary. The other reason is if you can do this really, really hard thing, then you can certainly do the things that are challenging you in your regular everyday life, right? The next one's encouraging distraction and avoidance. Again, We don't want to do anything that's going to artificially deflate the anxiety. We want that person to really, really stay with that anxiety as long and as best as they can. Giving reassurance, it gets a little bit sneaky sometimes. People are really, really adept at getting reassurance, even if they're not always making it sound like it's reassurance. So you really want to be aware of, like, am I trying to provide certainty where there is none, right? That's really, really the crux of it. Am I trying to give certainty in a place where there's no certainty to be given? Neglecting the core fear, which we really didn't have a chance to discuss, but is actually really important. So I'll give you a brief overview. The core fear is really when you distill the symptom down to its truest form, like what is the fear, right? I won't do this because, and one of the ways to get down to a core fear is to kind of keep asking the question and, right? I can't eat chicken. Well, why? Because I'm afraid it won't be cooked. Well, why? Because I'm afraid I'll get sick. Well, why? I might throw up. And why? Right? Because I might die, right? So a core fear, common core fears are like, I could die. A really common one around intrusive harm thoughts is I'm a bad person. So at my core, I'm just not a good person. Or at my core, I might lose control, right? There's this really big idea in the intrusive harm thoughts of like, I could somehow lose control and just murder my family or do something really bad. Someone else I love could die. That could be a core fear, right? And that could be around a lot of this magical thinking that's really common. And so you really want to figure out what the core fear is. And then every single exposure that you do should be geared towards that core fear, right? Because the other stuff is kind of a side effect of the core fear, right? Treating rumination as an obsession. We talked a lot about that. And then not looking for white knuckling and not teaching mindfulness skills. So white knuckling is this idea, comes from the idea of like, if you're in a car and kind of grab the seats because you're really nervous until your knuckles turn white. It's really the idea of just trying to get through it, right? So if you're doing an exposure that's too hard, you're going to see a lot of people who are like, I just want to do the hardest thing so I can get through this and get it done with. And these are the type of people who will do the exposure but do it while trying to suppress any kind of emotion or feeling that's coming out of it, right? So they're not actually willing to experience whatever it is that shows up. So one of the ways that you might notice white knuckling is if the person is like constantly looking at the clock. How much time is left? How much time do I have left? How much time do I have to do this? They might be asking you, how many more times do I have to do this? They're really not paying attention to their internal process. They're trying to kind of push all of that down in favor of like just getting through the exposure, right? So if you think about it, like if you guys do like a really intense workout, right? If the workout or the person that's giving you the workout or whatever says, okay, 30 more seconds, you can get through this. And you kind of just turn everything off in your brain and you just kind of like do it to get it done. That's white knuckling. And you really, when you're doing an exposure, you want to open yourself up to whatever those thoughts and feelings are. And that's kind of the opposite of white knuckling.